Thank you. And with apologies for the next panel, which is our opening panel for the day, I'd like to invite Mark McClellan, Rahul Rajkumar, Brian Klausner, Alan Pollard, and Hemi Tewarson to come up. And they're going to engage us in an exploration of multi-payer strategies to shift health financing toward value and population health. Let's welcome this panel and the co-chair of the Vital Directions Planning Committee, Mark McClellan.
Great, Mike. Thank you very much for introducing us, and it's great to be here with all of you. I'd like to add a belated welcome to those of you who aren't from North Carolina here to the state in this conference on Vital Directions. There really are a lot of opportunities to share experiences and to learn, starting with the discussion that we just had with Karen and Mike. We're focusing here in this session on payment reform. Payment reform gets a lot of attention in healthcare transformation efforts here in North Carolina, around the country, and actually around the world. And this is about, here in the state, moving to alternatives to fee-for-service payment. As Karen just mentioned at the end of her remarks, this is where the rubber meets the road on moving the resources to the kinds of things that we'd like to support more effectively for improving the health of our population. And I just want to emphasize that the motivation for this work isn't incentivizing health professionals. It's recognizing that the kinds of reforms in healthcare that are needed to shift the focus to improving health and addressing disparities more effectively require different ways of allocating resources, different ways of paying. So approaches that we've heard about yesterday, and there's some great panels coming up to address around enhanced primary care and team-based care, integrated mental and physical health, the use of telemedicine and digital health technologies, care coordination across medical and community service providers, integration of steps to address social drivers of health. None of these are reimbursed well under our traditional fee-for-service payments, and so it's really not possible to sustain new kinds of care models built around these potentially important approaches to improving health and lowering healthcare costs. So behind this notion of moving to alternative payment models is the notion of providing resources for care in a way that gives those involved in delivering care together in new ways more flexibility in how they do it, in conjunction with some more accountability for improving the kinds of key measures of population health and care experience and cost of care that Karen was just describing too. So more flexibility, but also more accountability to achieve reform goals. And nationally, there's been steady, if incremental, steps under both Republican and Democratic administrations towards moving from fee-for-service to alternative payment models. Another national effort that I'm involved with, the Healthcare Payment Learning and Action Network, is estimating that around 40% of payments nationwide are now in alternatives to fee-for-service payment. But so far, most of these payments have only been limited shifts away from fee-for-service. These are like the so-called shared savings models that some of you may have heard about. They show some evidence of improving health outcomes and care experience and some limited cost savings, but they're still mostly fee-for-service based payments. So it's perhaps not surprising that the resulting care reforms have not had that much of an effect on cost or many of the issues that we've been talking about today and throughout this conference. And so here in North Carolina, through a combination of changes in commercial payments, bigger and more rapid changes in Medicaid payments, in Medicare payments, both Medicare Advantage and traditional Medicare through approaches like advanced accountable care organizations, the state is on track for a much larger systematic change in payment that would take the share of payments in these alternative payment models here in North Carolina from something like 30% where it's been in the past year to over 70% in the next 5 years. And these aren't just the modest shifts. away from fee-for-service. These are ones that would involve substantial so-called downside risk, and what that means is much bigger movement towards payments tied to people and not just specific services that aren't necessarily the things that make the most difference for health. And that is an unprecedented pace of change for the United States, and I think anywhere else. So, as you've heard, success in these reforms is going to be challenging. It's why most healthcare organizations, most places around the country have chosen to go more slowly with only incremental payment reforms. It's not so simple as just adopting a new payment contract. New capabilities are needed on all sides, among health plans, among healthcare organizations, among the social and community-based organizations, and certainly some new expectations and experiences and involvement for patients and consumers as well. So this means new organizational structures, organize more around patients and their needs, integrated practices, not just individual services, new kinds of care models that target all of these potentially valuable interventions to the right people, and along with that, some real tougher steps to avoid unnecessary costs. And all of this has to happen with what Karen, I think, rightly described as squishy evidence at best to help guide it. So I think payment reform is interesting, and I'm really glad to be part of this panel because it brings together a lot of the other steps that we've been discussing throughout this conference. So we're going to hear some perspectives on the panel from different parts of the North Carolina healthcare system. And as part of that, you're going to get to hear about what's going on now with payment reform, what we've learned, what some of the challenges are, and what some of the opportunities are to address them from both local and national perspectives. We're going to start first with hearing from Rahul Rajkumar, who's at the Blue Cross and Blue Shield of North Carolina. And Rahul has been closely involved in leading many of these efforts for Blue Cross. Looking around in the audience today, I see people like Anita Bachman, others, United Health, again, Medicaid, commercial, Medicare Advantage plans that are also part of these efforts. I hope we'll get a chance to hear from them as well. And in addition to Rahul, we'll also hear from Brian Klausner, who's the Chief Medical Officer at WakeMed Key Community Care ACO and the Medical Director of WakeMed Community Population Health. Brian and his colleagues are in the midst of these transformation of capabilities and expectations on the healthcare system side, or I guess I should say the health system side now. And also really glad to have with us Hemi Tewarson, who is the Director of the Health Division of the National Governors Association. So North Carolina is trying to do a lot at the state level with state leadership on healthcare reform. A lot in a limited period of time. There are a number of states that have been at this for a while longer and have some very important experiences that can inform work here and also provide a complementary perspective. So very glad to have all of you with us today. We're going to start out with some opening comments from each of these perspectives on healthcare reform, starting with Rahul. As I said, Rahul, Blue Cross is in the midst of helping to lead many of these transformation efforts, not only in Medicaid, but in the commercial world and the Medicare Advantage world too. Maybe we could start with your introduction to where we are, where we're headed, what you see as some of the key issues in this big transformation effort with underlying payment reform in the state.
Yeah.
Thank you.
Thank you, Mark. And especially happy to be here today and see so many of our partners in the audience. I have to do something. Yeah, especially happy to be here today and see so many of our partners in the audience and Brian up here on this panel. I thought I might just start by a description of what's at stake. And you can come at this from a number of perspectives, but let's start with the level of our national finances. We spend about 18% of GDP on healthcare. That share is growing despite our very best efforts to control it. And what that means is that no matter your political orientation, over a generation, there will not be enough money left to do whatever you think our other national priorities should be. And that could be addressing climate change, it could be building roads, it could be educating our children, it could be defending our country. So we are in the midst of a profound national crisis that continues. I see a sprinkling of Blue Cross people in the audience. You could look at this from the perspective of our company. If we don't control the rate of growth of healthcare costs, we can all just go home. Nothing else matters. The third and most important is, as North Carolinians or as Americans, for our members that hold a Blue Cross card, so these are people that are insured, we believe that 25% of them spend more than 10% of their income on healthcare. That is their premium plus their out-of-pocket cost as a share of their income. That means that over time, we need to control the rate of healthcare cost growth to less than wage growth. That has not happened in my lifetime. I believe that we have a fighting shot at that in North Carolina, and I believe that the year that we can get those lines to cross is 2022, and I'll tell you why. And we need to sustain that for one generation in order to make a dent in this problem. Now, it will help if wage growth cooperates with that statement. So best case scenario, we see 3% wage growth or 3% GDP growth. That's optimistic. If we can beat that by 1 percentage point in healthcare cost growth and sustain that for a generation, we can make a dent in affordability. Of all of the things that we have learned about in healthcare cost growth and the science that we've developed, so we've built an evidence base, the most powerful tool we have is shaping the path for providers and changing the incentive architecture that they face. And we've done this at incredible cost. So I personally spent, with a team of 400 people, and Mandy Cohen, who's in the audience, $10 billion of your money to figure out how to do this. And it took us 7 years to learn about 5 things. And those things are that it can make a difference if you have a primary care physician that is accountable for total cost of care and quality. If that physician or system is in up and down risk, so it matters to be in downside risk, matters to control the rate of unit price growth, and it matters that there is a lane for independent primary care physicians. So I see Annette Dubard in the audience from Aledade, that we don't want to promote further consolidation in the healthcare industry, but there's a lane that enables primary care physicians that are independent to remain independent. So we at Blue Cross have pretty ambitious goals, and the goals are that by the end of the year 2023, 100% of our members will have a provider that's accountable for total cost of care and quality. We think we can get halfway there by next year. We are at 48.4% right now. I just checked the numbers this week. It depends, of course, on what you include in the denominator. So there's a string of footnotes attached to that number. But let's assume that we get to 50% by next year. In order to do that, we have had to play at 3 levels of the healthcare delivery system. So there are systems. There are 10 systems in North Carolina that have revenues over $1 billion. 7 of them are in this program, which we call Blue Premier. We announced the 2 largest last week, which are Atrium and Novant. There are 3 that are outstanding. Those are Mission, New Hanover, and Vidant. But 7 of the 10 largest are in the program. The second layer is independent primary care. So for primary care physicians that are independent, we have a deep partnership with Aledade. We have given them our contract. We hope that they will staple it to the application of the Medicare Shared Savings Program and go out and recruit independent primary care physicians with a program that has slightly different features. So there's risk in it, but the risk is asymmetric because an independent doc doesn't have the balance sheet to take a symmetric 2-sided risk. So it's right-sized risk for independent primary care physicians and powered with the arsenal of tools that Aledade brings to the table. And the third layer is for advanced primary care practitioners. So there are unique practices around the country that you may have heard of, like Iora Health, CareMore, CityBlock, that we have partnered with, that we have recruited to North Carolina, that have a completely different way of delivering primary care. They operate at radically reduced panel sizes. They do things that are unrecognizable to most Americans, like You're a newly diagnosed diabetic. Your Iora Health team will take you on a tour of the grocery store. CareMore docs are famous for clipping their patients' toenails in their health hubs. We'll send a physician to the patient's home if the patient can't get into the office. And they finance these models of care by taking enormous amounts of risk and winning under those risk contracts. And so we have a third lane for advanced primary care physicians, practices that are willing to take on the incredible amounts of risk. Our goal is to do this in deep partnership with providers. We have a long way to go to be a better partner to the providers that we serve. I think, Brian, you can speak to this, but I just want to...
I'm not nodding.
Yeah,
No,
it's okay.
Just smiling.
The last thing I'll say is that to be a good partner means to be in a long-term partnership. So the contracts are long-term, that we commit to sharing data with providers, that we have a rational and simple approach to quality measurement. We have a long way to go on that, but that's our commitment over time. And that we walk in this journey with the providers that we're partnering with. And the very last thing I will say is that getting this far has been the hardest thing I have done in my professional life, but it is nothing compared with actually changing the way in which we deliver care. And so if I think of the jobs that people like Brian have, Matt Ewind at UNC, Tom Owens at Duke, they're clinical leaders. They are now in these contracts. We've thrown our hats over the fence together, and that work is incredibly difficult. And our job as the payer is to walk with them in that journey. Let me pause there and turn it back over to you.
Great. Thanks very much, Rahul. So I would like to turn to that provider side. Brian, Rahul talked about the transformations happening on the payment side. And it's not just Blue Cross, although Blue Cross is leading a lot of these efforts. Many other payers in the state, including efforts to align with Medicare as well. This is creating some expectations around transformation on the provider side too, and we're not just talking about adding a few capabilities. There's a lot of new expectations and capabilities to go along with it, and really nothing short of culture change on the part of the way healthcare providers think about their role and their responsibilities and how they work with their patients as people and the community. Your group has been a leader in these efforts. Would very much like to hear about how that's going and what you see as some of the big achievements so far, but also the big challenges ahead.
Sure. So, and just to be, I think I confuse a lot of people because I have a couple of jobs, so which my wife never gives me grief about. But first one is and I think all these kind of allow me to have a boots on the ground type perspective. So first, I'm a clinician still. So I've worked hard to maintain 40% clinical time, working at a downtown clinic in Raleigh, primary care clinic, but also that serves as a safety net for our Hotspotter program, which I'll talk about in a second. So usually homeless patients with severe social determinants will end up in my clinic. My primary care background is really around homeless medicine. I came down from Boston. People always give me slack because it takes me about less than a minute to mention that I came from Boston Healthcare for the Homeless, but that's where I started. We were really doing population health before everyone knew what population health was, with a patient population whose mortality is in the mid to high 40s. And so with that background, I came down here. And chief medical officer of WKCC. So that's been a really fascinating job and I've been CMO since 2014. But so we have over 400 docs. It's a combination between WakeMed, a hospital system, and a group of what we call fiercely, not just independent docs, fiercely independent docs. And how we kind of have worked and navigated what is kind of an often times messy, complicated, and even a slow path toward value-based care, which is getting accelerated here in North Carolina. One of our challenges, honestly, is when you look at outcomes in terms of cost and quality, where we're 100% with quality in Medicare, we're top 10% in over half of our commercial quality measures and high patient satisfaction. It presents a challenge. So I'm not just saying all that stuff to brag, although I am a little bit, but I'm saying that to say it's a challenge to how you engage and how you continue to improve and how you kind of deal with what we see as record burnout rates from a primary care and from a physician perspective. And so how you navigate providers through this evolving world away from fee-for-service, where mainly they're still dealing in fee-for-service, as you kind of referenced, toward this evolving world of value-based care. And an example of that is, even though if you look at our cost, which a lot of times are thousands per beneficiary lower than a lot of ACOs around the country from a Medicare perspective, we haven't got any shared savings from Medicare. And we see a lot of these ACOs, I won't pick on Texas or Florida, but you see a lot of ACOs with high benchmarks who profited on the way up, who are now profiting on the way down, whose benchmarks are still thousands above ours, who are actually getting shared savings, because one of the issues with shared savings is you're judged against yourself. So, one of the historic evils around that is that it does penalize people who are high performers to begin with. And so it's been a challenge, but definitely facilitated by payers who get it and payers who recognize this, and kind of a collaboration, which we'll probably talk with at a panel perspective. So much more collaboration between payers, between providers, talking through these issues as we try to align goals around patient care. And then the third and final position is I manage our community population health. And if there is any silver lining of lack of Medicaid expansion, which there's none at all, but what it's done, honestly, in North Carolina, it's forced us to realize, as we keep talking about moving to risk and how we do that, I think a lot of the hospital systems in North Carolina have looked up and realized what we have always realized, but realized, well, we're fully at risk for our uninsured patients. And that makes we've always known about that, but as we evolve toward value-based care, I think we've been able to put it better in the context and the language of value-based care that we're all talking now. And we look and we start doing different things. And it's very, very simple. It really is. I mean, it's this intuitive idea that has conveniently or even strategically has been ignored in a fee-for-service world. And the fact that has happened has literally almost bankrupted our country. But the secret is healthy patients cost less than sick patients. So, you know what? We should probably work to keep patients healthy, and they won't cost a lot, and they'll be happy. And it's amazing how intuitive that is. And so when you're in a fully at-risk model, it forces that on you, and it forces you to get out of your silos, get out of the medical hospitals and the clinics, and you get into the community around you where pathologies live and disease lives and cost lives, and 80% of all healthcare costs are in the communities and are outside of our silos. And so how do we address social determinants and how we address mental illness? And that's been a fascinating explosion of collaboration across healthcare systems. I'm biased, but I think the collaborations, we all have competition, but between the three systems here of Duke and UNC and Wake Med, and we're all meeting and we're talking and we're having groups about how we manage these patients in collaborations with the communities, with the community-based organizations and with governments and local governments. So it's really kind of accelerated, I think, our perspective on value-based care when you look up and you realize, well, we are fully at risk, and hopefully one day we won't. And when I say we're doing these things, it's for a very small percentage that, but it's a start. It's a start. Those are the ones that are hemorrhaging money and hemorrhaging bad outcomes, all that are avoidable if we're able to engage. And so we've been able to prove the intuitive. To Karen's point, we're really, really busy. I mean, there's patients literally dying all around us. So there's a lot to have the time to publish that and look at that. We're just going full sprint just to save the next 10 patients that are popping up on our dashboards. But internally, and I think across the community, we've been able to prove the intuitive that if you do get outside the silos and you actually manage health, a lot of the things that are theoretic in other realms have been very practical, and we've seen it play out for our hospital.
Great. Thanks very much, Brian. And if you look at your program, you see that also listed was Alice Pollard, who's the Director of Health Access for North Carolina Community Health Center Association. She is very sorry she can't join us this morning because of a late emergency that arose. What Alice is doing, I think just picking up on Brian's comments, is through the community health centers has had to take a lot of steps in the presence of a high rate of uninsured patients, working with hospitals individuals who do have, especially in the absence of coverage, and some strong financial, economic reasons to try to find ways to keep some of these individuals healthier, to find effective models for doing that. One of the things that Alice wanted to emphasize for this panel was the importance of really directly engaging people. Getting consumers on the boards of healthcare organizations that are trying to become more focused on what really matters to patients, and finding ways to track whether the concerns that are most important to these individuals really are being addressed. And Brian, I think it's very complementary to what you and Rahul were talking about, where there is this kind of new alignment that comes with limited resources and trying to focus the resources on people and accountability for outcomes that supported all of that. So maybe we can come back to some of those issues in the discussion too. But first, Hemi, I'd like to go to you. You've seen a lot of reforms in states around the country, many of which have been going on for a lot longer than the ones we're talking about here in North Carolina, and I'm sure in other states, just as here, things don't go forward in a completely linear fashion without bumps, like not having a budget agreement in place and things like that. Would really appreciate your thoughts on reflecting on how we're doing in progress, and how North Carolina might fit into a broader national set of experiences in these reform efforts.
Well, first of all, I'm really happy to be here, and I'm very impressed spending the last 2 days listening to all of you and what you're really trying to achieve here in North Carolina. It's an ambitious plan. It's a plan, as Karen said, we are watching, and us along with lots of different states across the country. So one thing just to say, just to preface my remarks, so in the National Governors Association, we have to focus on what the governors care about. It's like our mission, this is what we do, and I sit in the Center for Best Practices, and our job is to figure out what is the innovations going on across the country, whether it be in the private industry, whether it be another state taking the lead, and how do we bring those learnings to other states. So we, of course, are watching this unfold in North Carolina with rapt interest, and really are supportive of what you're trying to do here. I was reflecting on what I could share with you, because I could talk a long time about what's happening and what we've seen, but just to give you a snapshot. So one of the things I love about my job is going into each of the different states and seeing the distinctions between how they're operating, both in their market, what their economic drivers are, what their populations need. And, just to give you a sense, in the last 3 weeks, I was in Kansas, Pennsylvania, and Wisconsin. So now I'm here in North Carolina. And they are all different. And there's things to think about amongst those differences, but there's also some common themes. And so what I thought would be most helpful is to just give you a snapshot of what we've seen. We're constantly being asked by different states, like, who has solved this? Who has figured out multi-payer alignment, and how have they solved social determinants of health? Because we know that's driving up the healthcare costs. Who has done it well? Where can we get the evidence, and what can we do in our state to make that happen? Because really, at the gubernatorial level, when you see something that's worked, you want to borrow. There's no need to create something new. You want to learn from it and say, oh, that worked over there, we're going to try it over here. But unfortunately, we're early in this journey, right? Even though there's been states trying a lot of different things, and North Carolina is now the latest on the list, we don't know yet what is exactly working. So what I thought would be helpful would be to share kind of what we've seen just at a very high level, and we can get into the discussion of kind of where we go from there. So a couple things we've seen. So historically, the governors have been focused on Medicaid, right? Medicaid has been the big budget driver, 30% on average of state and federal cost of their budget. And they actually have to balance their budget, as we talked about yesterday. They can't print money. So they have, a lot of the innovations from years past has been focused on the Medicaid program. How do we ensure it's an efficient program? And, Oregon, of course, was kind of out front thinking about how do we cap the cost of our program. I think I would say the past 2 to 3 years at the gubernatorial level, we've seen a renewed interest in what about these other markets? Even though we don't control the commercial market, we're hearing from people in our state that healthcare costs are too high. And there's a lot of reasons that's happening. There's different types of commercial health insurance plans where people have higher deductibles and they have higher copays and they're feeling it. And then, of course, they're coming and telling their, leader of their state, hey, we can't afford health care. You need to help us. And so there's a renewed interest, at least from where I sit, on looking kind of across payers, which I think is an important shift, because really if we're going to solve this, we have to look across our markets. It can't just be in Medicaid. It can't just be in commercial. It can't just be in Medicare. So what I've seen is this renewed interest of how do we align? And that's also coming from the providers. The providers are experiencing, and I know you're having this in North Carolina, all these different arrangements, right? Like Medicare is over here doing, what it's been doing, and it's some great work. Some of the commercial payers are trying different things, and of course there's Medicaid over here. Really hard to manage that. And we've been in stakeholder groups in different states trying to talk about this and thinking about alignment. And that has been a continued challenge. How do we really figure out a uniform way? And right now, there's not a clear path to that. But there are a couple of states, and I just want to share those with you, where they've tried to do a little bit of this. So we have like the Tennessees and Ohios and the Arkansas of the world who thought, you know what, we're going to do episodes of care. It's a discrete way of thinking about how we can do multi-payer alignment. Tennessee got their commercials to come in. They couldn't quite get Medicare to agree to what they wanted to do, but they got Medicaid and they got commercial, and that's because they had a really strong managed care system historically in place that they've rebuilt since 2008, where they could basically tell the commercial plans, well, you're going to play in my Medicaid market, you got to do the same thing on your commercial side. And they combine that with focusing on primary care medical home as a sort of comprehensive look at what to do. I would say Massachusetts has, had, and I'm from Massachusetts too, so great state.
Took you 2 minutes.
I know, it took me longer to say that, but yeah. Born and raised, yeah. So, in that state, they said, okay, a big investment, we're going to have a healthcare cost commission. We're going to have benchmarks across all of our programs, because we know we cost a lot. We have a really good system, but it costs a lot of money to get healthcare in Massachusetts. So they had their state legislation in place. They are fortunate to have a lot of investment to build that system, which other states don't have. But there's a lot of learnings from that. What did they build in terms of building benchmarks across all of those programs, and has it improved outcomes? And you'll see Rhode Island and Delaware, two smaller states, are following that suit, learning from Massachusetts and building that. Oregon, who I talked about earlier, who had a cap on their Medicaid program, has now got legislation to apply it to commercial, and they're looking to that model as well. So I think that's another thing to kind of follow. And I think there'll be a couple other states that follow on that as well. And then I just want to mention Washington State, and then I'll stop talking. And it's something I think that would be interesting for you all to look at. I know the state has been looking at that. So we helped them with their waiver back in 2016. So they're a couple years into it. They had a mature managed care system on which to build, and they had a big, ambitious waiver they got approved from CMS, where they said, okay, we're going to push to value-based payment, and they're organized where they have an authority that's over their public employees and their Medicaid folks and teachers all together. And they said, we're going to go in 5 years to getting to value-based purchasing in 90% of our state finance healthcare and 50% of our commercial market, and our healthcare cost growth is going to be lower than the national average, and we are going to implement VBP across all these programs using the same philosophy. They got big investments to actually build what's called accountable communities of health, where they had 9 regions where they said, okay, these community organizations where we have all the different partners in the communities, figure out what that region needs, and then we will invest in infrastructure and programs that serve those needs, which I think, as we've been talking about for the last 2 days, really important component, building in the local need into whatever reforms that you're going to push out at the state level. Really, really important, because it matters and it's going to make a difference. So they're a couple years into their journey. They exceeded their targets. They did an incremental increase on the value-based purchasing. They've exceeded their targets on that. I think they're still trying to figure out what the outcomes are. Part of their piece of the waiver was to also invest in social terms of health, and they chose supportive housing and supportive employment. And the Medicaid program to invest in those 2 pieces. So I just kind of throw that out there as things for all of us to care about. And I could go on and on, but I'll stop for now, and then we can talk more.
It's great to hear about all of those experiences, and I'd like to follow up on a few of the topics that you all brought up, and maybe starting with cost growth. So obviously that's right front and center on the minds of Americans heading into an election year. As Rahul very eloquently said, we haven't solved this problem, and I'd say even despite a lot of efforts, many of which you reviewed, the impact so far of these value-based care and payment reforms on costs has been pretty limited. And back here, and getting us back to North Carolina, just listening to Rahul and Brian, there's several things happening at once. One is some big, bold efforts to try to really improve population health in ways that we haven't even tried to undertake at this kind of scale before. Second is we're doing that in a way that we'd like to get costs down, as Rahul emphasized. And third, as Brian said, because the healthcare costs, we're not Massachusetts. We're not number one in the U.S. I guess they've moved to number 2 behind Alaska, so that is progress with Massachusetts value-based care reform. North Carolina started out further down. People are still hurting here, as Rahul emphasized. So that seems really tough, both getting the costs out and taking on all of these new steps to improve health at the same time. You can't do everything at once. Would appreciate any reflections from you all about what you see as the biggest feasible focus for getting costs out of the system in a reasonable time period as we're doing all this. And I get the point about investing in health and helping improve long-term outcomes for, say, people who otherwise might go on to develop diabetes or other chronic conditions. But that's not going to help with premiums next year, and at least not in a big way. So what is the attention you're paying to really get at these cost issues in the short term?
These microphones are so complicated. Right? So I think for us, and I'm biased because we started and developed a hotspotter model. But when you look at population health, and it's overwhelming, you look, okay, we have a panel of 65,000 uninsured. Where are we going to get started with population? It's overwhelming. Yeah, and so you look at those stats so you start with that 1%. You look at the 1% that are driving 25, 30% of your costs, not only because that's where the low-hanging fruit is, but that's also where you can kind of develop and mature population health skills. So when we looked at our analysis, and it's the same almost in every single patient population, you're going to have a large percentage of costs due to a very small minority of patients. Some of those are, catastrophic comas and car accidents and things that aren't impactable. But there's a lot, especially in the uninsured and Medicaid population, where it goes right to social determinants. And so for us, as we look at these panels, both from an ACO perspective and from an uninsured perspective, it's helpful to start with that because one of the ideas I think that we really push, especially in the hotspotter models that we run, is avoidable, expensive, and people in the room have heard me say this before, but there's a lot of avoidable, expensive human suffering that we can get at. And if that's, as we all kind of start the transition, and then you develop those skills and you can then start applying it to your top 5%, top 10%. I think from a boots on the ground perspective, that's a tangible way to start. When I go to my, the ACO providers, they have panels of 3,000 or 4,000. That's a lot of patients, but let's look at your highest risk, highest cost patient. Let's look at your top 3 ED utilizers. And it goes to a lot of the care more models and the very the small panels, intensive care, kind of a concierge type model for population health. But that's where we've focused a lot of our efforts to begin with.
So first of all, I want to say it's hard to think of a provider organization that's been more courageous than WKCC, and Brian, as a leader of that organization, I have tremendous respect for you. Let me say what you may be uncomfortable saying. WKCC is one of the first Medicare ACOs, took risk, was a next-gen ACO model, so really a leading ACO in the United States, and certainly in North Carolina. So we as a payer think that there are a few tactical areas within healthcare where we can make deeper investments. One of them is in primary care, so increasing the relative payments to primary care. We spend about 7% of our total book on primary care right now. We think that number could be 10% or higher. So just trying to move the needle for primary care. Our risk model and most of the risk models that exist that are effective treat the primary care physician as the quarterback. And that quarterback needs to be well resourced in order to better direct care for the patients that we're giving them. The other is behavioral health, which is area where we as a nation have dramatically underinvested. And as a result, we now have an access problem that we're all waking up to. And suddenly find that when you call a behavioral health care provider, they may not answer the phone because half of them are in cash practices. We need to invest more in behavioral health. Our approach to doing this is through an alternative payment model for behavioral health care providers where, similar to primary care physicians, if they can help us reduce total spend, they will get a cut of those savings. But we think that this is a major area for investment where we can reduce the total health spend by making a tactical investment. And the third is drivers of health, social determinants of health, which you just had a speaker on, so I don't need to comment more on it. But I agree with Dr. Cohen, Dr. DeSalvo on developing the evidence base for the drivers of health. The last thing I would say is just to pick up on something that you said, Brian. With providers like you, I often feel like we have to deliver a finely tuned message that we respect everything that you have done, but I still think that every provider still has room to improve, and so that is the challenge of comparing you to a provider, say in McClellan, Texas. That improvement for you, I recognize is harder, but still important.
Well, and let me address that because that's actually a strategy for our ACO. Is we absolutely will say, guys, not everybody is great at everything. So our strategy, really, our main strategy, is getting our providers their individual data and saying, go look for your area for opportunity. We mandate PDSA cycles, and we think that we haven't even really scratched the surface. So yes, we're doing better than others, but there, to your point, absolutely room to go. And the strategy is through analytics, getting the data, getting the analytics, saying where's your area of opportunity, address that in a quality improvement cycle. And one quick point to Rahul's point, just practically, like how this actually works in a state where we, one of our messages to primary care is this is happening with or without us. It might as well be with us. This is going to be your career moving forward. We're moving toward value. Accept it, and let's go. Let's try to take the lead. And so we have pod meetings, and we have every quarter we have all our 450 docs come, and we'll talk about what's important, where our strategies are, and what's the what we need to focus on, what are the tools, what are the resources. And we meet with Blue Cross every quarter, and we talk about, okay, this is what we heard at the pods, and their teams will come back and say, okay, this is what we're going to do. And the behavioral health was a perfect example. So we had Blue Cross come to our pod meetings last spring and talk about the behavioral health initiative, which is really, if you look at it, you could do a whole hour on that. Mm-hmm. Very innovative. It's trying to lower medical cost by better addressing behavioral health cost, because we saw in our analysis that our medical cost was double in patients with mental illness. Not the mental health cost, the medical cost was double, and we weren't adequately screening that, addressing that. So we go to Kate Hobbs-Knudsen, and we say, hey, this is the data we had. And she said, well, we're going to come to you. That's the data we had, too, across our population. And this rollout that probably wouldn't happen, 5-6 years ago in terms of provider engagement, and it's been incredible because providers are finally saying, you know what, I can better manage my patients. I always knew that patient had severe depression that wasn't addressed. We got the predictive modeling. We were able to sit down. We were able to take the time. I realized that this is going to, cut their costs in half, if I better address this. And it's resonating into recognition of impactability and actually application at the clinic level. But that's the sort of thing when you're in a state where you're moving toward value. The collaboration, I think, is unique in North Carolina between providers and between insurance companies and hospitals, because we know we're all going the same way. And we know we're doing it for the right reasons, right? Yeah. So it's been just kind of a practical example of how this actually works from a clinician, day-to-day clinician, getting these tools and resources to them, because that's where population health lives, at the individual provider and patient level.
Yeah. I do want to come back to the effective strategies for new kinds of collaborations. That seems so important, all this work. But first, Hemi, I was disappointed to hear that there's not some secret NGA manual somewhere on how states can reduce costs and improve outcomes at the same time. But any tips to add on this issue around how do you get the cost savings? savings?
Yeah, and I just wanted to reflect. So the past 5 years, we've invested in complex care populations, working with, I think it was about 12 states, figuring out like who are the high cost, high need populations, and how do we build a system to actually address that. And I love that you brought up behavioral health, because our last project was about behavioral health, and North Carolina participated in it. And it was actually highlighting what the work that Arizona did. They have a very mature managed care system, and I think it's really important to have a strong managed care system in the way they actually rolled out their project, and that's something that North Carolina is going to work towards. But the way they did it was they built a very strong stakeholder engagement process, but they also figured out the financing, and I always feel like that is the trickiest part of all of this. They figured out how to blend not just Medicaid dollars, but also the block grant dollars and other funding that these providers are getting, because many of the behavioral health providers may not bill Medicaid, right? They're used to block grant. So they have built a system where they're bringing people along. And we modeled them for other states because of their, I think, incremental success in doing that. And a couple of things I just wanted to share with you is they have identified who were the complex care, the highest need patients where we can really focus the interventions. And they had a pool of money to then allow payments for Medicaid providers who actually met certain benchmarks for integrating behavioral health to help them come along and build up their infrastructure systems and then actually support them in the actual implementation. And I think that was a really helpful piece to bring providers along the way, those behavioral health providers specifically. The other thing I just wanted to mention, which I haven't heard about yet on this conversation, is justice-involved populations. That's another piece that they really have taken on, and I think it's really interesting to just share that for you all for your consideration. Through this pool that they have, they established 13 co-located with probation and parole integrated health clinics statewide to serve probationers and parolees, and they're providing on-site MAT, physical, behavioral health services, employment support, support for food insecurity, housing, and forensic peer and family support. And they're doing that because they're realizing that people are circulating in and out, right? Maybe they get MAT while they're in the corrections setting, and they come out and they're not connected with the right services, and guess what happens? They cost the system a lot because they go back in. So I just share that for you all as you're on your journey here, because we see a lot of promise in what Arizona is doing. And I also can't emphasize more that really figuring out the financing and how you incrementally bring these providers along is so important. So.
I think my microphone's actually broken. I'm going to steal yours and just jump on one comment, because that is, and you develop these things out of necessity when you really look at the analytics. And what you're attesting to is what we've seen from the uninsured perspective. And one thing that I think we're missing from a social determinant perspective, and it's a big one, is the bidirectional nature of social determinants, right? That our hospitals are full of patients with unmet social services, with unmet social needs. But our social services are full of people with unmet medical and mental health needs, right? And so when you look at, and we started doing this to Sig Hutchinson's credit here in the front row, like we developed a Wake County Population Health Task Force that had the jails there, the schools there, all three hospital systems, DHHS, the Wake County Health Department, and we talked about how do we, with what we've learned in our medical silos of population health is data drives everything, right? We can say all this intuitive stuff like, oh, we need to better treat mental illness. When you go back and say, we need to treat mental illness because it's doubling our medical costs, you got to slap people in the face with analytics and then continue to emphasize, how important it is, so we just can't ignore it. And so we're looking at developing whole person analytics. So not only getting all this medical information, not only getting the utilization data from Duke and UNC and Wake Med, but getting jail data and getting EMS data and getting homeless data and coming up and saying, okay, the total societal cost of this patient, if we don't do something, is going to be $350,000, $400,000. If we do an intervention like housing, and they've done this in some cities, including Los Angeles and the Silicon Valley.
Washington. No.
Yeah, and that is, you know what, it's going to drop cost. The FIT program, so the prison reentry system, that's exactly. So right now we have a committee that I co-chair with Lauren Freeman, who's our district attorney at Wake County. And she's interested because of exactly what you're saying. We had an example last year where we had 3 people come out of jail without their Medicaid reinstated and completely detached, and 2 recommitted, and 1 was in our hospital within a week. And it was absolutely 100% inevitable because these were patients with severe mental illness that were discharged without follow-up or medication. And it's like, what are we doing? Not only from a humanistic perspective, from a cost perspective. Like, what are we, And so I think to do everything you're doing, but analytics is so important behind all this, not only hospital, but community-based analytics, because hopefully that's going to drive not only the social determinant, but the bidirectional nature of it, which will then get communities involved in local governments and jail systems and police forces and homeless services. So
Yeah. Yeah, just and we talked a bit about that, had a great panel discussion on that yesterday. Just would emphasize from what I've seen here that seems quite distinctive and fits with some of Hemi's comments too, is that there is critical attention to finding the most important data elements, not necessarily getting everything, but bringing in important information that can enable timely decisions for patients and for improving health and avoiding costs, whether it's in the incarceration setting or otherwise. But to make that possible, there is this kind of collaboration, new kinds of collaboration that reflects a level of trust and a level of shared engagement with the financing behind it to start that's making a big difference too. There's a lot more we could talk about in this. I would like to open this up to questions from and comments from those of you who are here. There are a few more things I'd like to discuss, but I'll try to work them into comments from all of you. I know there are a lot of people here who have who've been deeply involved in these efforts and have a lot to contribute to how we can make payment reform work successfully to achieve all the goals we've talked about. Who wants to start? Pam?
Hey.
And let us know who you are, even though I know who you are. But
Okay. I'm Pam Silberman. I'd be curious actually for Rahul and maybe for Brian as well. The research literature talks about the fact that safety net organizations generally don't do as well in value-based payments, and when you move to payment reform that is based on quality, and there's always a concern out there that organizations may try to drop their riskiest patients as we move to value-based payment arrangements. So what is Blue Cross Blue Shield doing to ensure that we don't have systems that encourage cherry picking, or a new term I just heard, lemon dropping, for the riskiest patients?
Yeah, and I just would say this is a great topic, Pam. It's not just a Blue Cross issue. This is a system-wide issue. We're trying to move in North Carolina to aligned payment reforms to make sure those aren't building in kind of the systematic worsening of health disparities. How do we really make sure these steps are addressing health disparities at the same time as they're improving quality and lowering costs?
Yeah, well, I really appreciate the question. Let me just say that the literature on the interaction between income and different models of payment, and whether pay for performance, ACOs, bundled payments, advantage or disadvantage safety net institutions, I think is emerging, complicated, and also controversial. And there's an explosion of complexity in that question that I'm not the world's expert on this, but I just want to acknowledge that there's not a simple statement that I could make on that literature. A lot of the literature comes from the CMS Hospital Readmissions Reduction Program, which basically looks at performance and arrays hospitals nationally into quartiles on their performance. So our programs don't do that. A health system or a provider, as Brian said, and so Brian may prefer to be compared to his peers, but our program compares you against your own historical performance. And so historically, if you had a high number of extremely sick, low-income members, that's what you're compared against. It rewards you for your quality of care, for your baseline efficiency, and also for changes in risk. So that risk has to be captured in diagnosis codes. But if the risk of your population is changing, if it's getting worse, we give you a kicker in how we trend the benchmark forward. So it's built into the math of the program. Of course, every provider that we talk to will pick it apart and make the assertion, rightly or wrongly, that they're advantaged or disadvantaged. But it's a great question, and it is not our intent to disadvantage any type of provider, but it's to treat everybody fairly.
All right, Brian looks like he has something he wants to
Yeah,
say.
I think it's a scary question, because I think you might be identifying the fatal flaw of value-based care. I mean, you really might, in terms of, and there's some studies and some evidence to suggest that this push toward value-based care is worsening healthcare discrepancies. Because when you look, I mean, and you guys have probably heard this a lot throughout the conference, that 80% of health outcomes and costs are related to social determinants. Yet, is the individual provider, does that even get taken into account with the risk scores that we're held accountable for? And I had a perfect analogy, or a perfect example. 3 years ago, I was in my clinic, and I had two patients, both with diabetes and CHF, and one was a local CEO, and one was a homeless patient. And we went through, the CEO came in with his wife. He had a trainer. His outcomes were great. His A1C looked great. I get credit. I look good. All his care gaps are up to date. And within like 12 minutes, he was out. We were giving high fives. This is awesome. And we bill, a 99213, and we're set. Homeless guy comes in, and we're 45 minutes in, and I'm still going through his bag of medications, trying to figure out how we're going to give him insulin. Still the same fee-for-service reimbursement code, although I did 99214. But his A1C was 11, and I was doing backflips because it was 14, and that truly backs him away off the cliff a little bit. But I think the issue is that while we recognize the social determinants, we're held accountable for cost, not pure cost, risk-adjusted cost. And when you look at it, we're not taking into account the social determinants that truly drive the outcomes. But I think it does point to the work that Mandy's doing. And we can't give credit if we don't know it's not in our systems. We haven't screened for it. We don't know how much food insecurities will add to the risk because we've never screened for it. It's not something we can capture in our data. These risk scores are all, extracted out of claims, and some are starting to go into kind of census tracking and zip codes, but even that is an imperfect science. So the first step really, and this is why we have to move on this, I think, or else if we don't, this could all fall apart if all of a sudden we start cherry picking away from new patients, poor patients. I think to what Rahul's saying, being judged against our baseline, that's really helpful. I think that gets it. But how that incorporates new patients so the first step is to screen, study, analyze, and then build it into risk codes and do it in an expedited manner, because if not, we could all 2 or 3 years from now, we could, and I always say, are we going to repeat the biggest sin of our fee-for-service past right from the get-go? Right as we go into value-based care, are we going to once again create a system that discriminates against people based on socioeconomic lines? And there's some evidence that that's happening, and that's really scary. I think we all have to be conscious of that. When I've talked about it to people and shared that, it's pretty frustrating because I don't think any of us have an answer besides we got to get moving on how we track and screen and identify and get credit for the social determinants that we're taking care of.
Yeah. To say that's why, just a few more comments on this topic. I know I'm the moderator, but we think about this a lot in the reform efforts here and elsewhere. First of all, remember this is not about fee-for-service. So unlike the hospital incentives around a DRG payment, where there are things that you might do in terms of fundamentally reforming your care, but you really aren't shifting the resources to enable that to happen. It becomes easier to do things like drop the patients, change an admission to an emergency department visit, shift the patients away. This is about more fundamental changes in care, not just billing the 99213s, but getting to, like you were saying, a whole different model for taking care of the guy who's not the CEO. On top of that, the data is really important, and here in the state there's been a huge emphasis first, as you just heard from this panel, on getting key social driver, social determinant information included, and that is a foundation for risk adjustment, for further steps, and certainly for monitoring more effectively whether there's a problem. And I just want to come back to the importance of culture and engagement here, and this is a point I think Alice was going to try to emphasize, that if these steps are undertaken with just an attention to payment models and traditional measures, we're going to miss. Instead, by having community-based approaches, which people like John Lumpkin and others talked about yesterday, having an opportunity for really putting the culture, Brian, that you're trying to develop front and center in collaboration with the payers. It doesn't mean we'll solve these problems, but it does mean that as we move away from fee-for-service, there's much more attention to really keeping an eye on the ball of what we're trying to accomplish and what kind of new culture in care and health that we're trying to build. Yes, or whoever's next.
I'd like to switch this to some action steps for the future of this collaboration. You've touched on a number of things related to this whole issue of the population, Brian, and the task force that y'all have developed. You know, I think horizontally we need these types of models, even though there's not much research attached to them, to get out across the state. And particularly in our rural areas, we're not addressing in the state the total social decline of our rural areas, particularly eastern North Carolina. When you look at I-95 and go east, if we were the 51st state, we'd be the poorest in the whole nation. You know, Appalachia is doing better than eastern North Carolina is, but we've never addressed that. And on the issue of mental health, it's like mental health is the stepchild of health. It's the part that we don't want to deal with. And in North Carolina, what we really lack is programs in dual diagnosis. The substance use people and agencies and systems still act as if it's an issue of willpower, not brain disorder. And so the costs keep rising for Medicaid and private insurance, but we're not addressing the causes of that rise. And so we're looking at setting up a model diversion program in Robinson County on dual diagnosis to stop the repetitive prison sentences. And then philanthropy could play a really key role in this by looking at some of these models and issue some RFPs. And so I think we really need to look horizontally at the creative things that are happening in North Carolina and the nation, and really be more proactive in seeing how we could spread out the creativity that's happening in the state and the nation here in North Carolina.
It's a great comment. I'm just want to be mindful of time and bring in blending funds together. And we've talked a little bit about mental, physical health integration. We haven't talked about rural health and some of the real tough issues combining access, low income and economic development, and efforts to improve care. And I don't know, Rahul, if I can put you on the spot for that, but you all are doing a lot to try to extend these models to rural and lower income communities.
Yeah, I mean, sorry. Thank you. Yes. So, I mean, one of the unique challenges of North Carolina is that most of our state is rural, and even our largest markets are. We really only have one city that is, considered to be a national-sized market. And so a lot of the care models that we are financing were really developed for more densely populated areas. So you heard me talk of 3 track systems: independent primary care and advanced primary care. The advanced primary care providers all exist right now in densely populated areas. And so we are working with 2 of them to deploy slightly different variants of these models in rural areas. And it requires just a different way of thinking, of hub and spoke bricks and mortar. So you may have a care center and then have mobile vans that can reach different rural areas within a 100-mile radius. How you size a model for Charlotte is different than how you would size it for Fayetteville or Asheville. So it's one of the great things about being in North Carolina is that the problems that we are solving here are of applicability to the entire nation. We have every type of region, every type of city, town, village here in the state.
Yeah, it's really diverse. So we've got just a few more minutes, and I want to try to get in as much questions and comments as possible. On this side, was there I know there's some hands up.
Thank you. My name is Meryl Pothin. I'm an MPP second year at Duke. My question is, as we talk about reducing costs while improving outcomes, we should talk about who is defining the outcomes. There's a ton of metrics for providers, for payers, and I'd love to hear your perspectives on the role of patient-reported outcomes when we talk about value.
I think you're right. And I think that is one of the things from an outcome perspective that can overwhelm provider, especially if you're in 4 different commercial contracts with all the different outcomes and the quality measures, and that's where the strategy really is: how do we push through this while not burning out our providers? I think from a patient outcome perspective, again, this isn't a capitated model. It's not all about cost. It's about cost and quality, but it's also about patient satisfaction. So the triple aim. And so I think that's one of we really are. There's been a lot of focus on cost and quality, and there's a couple of patient satisfaction and patient experience questions in there. But actually, Blue Cross, we just had a meeting. I'm on the physician advisory group at Blue Cross, and Dr. Key had a great meeting on Tuesday about how they're going to further incorporate that, how they're going to structure that. Do we coordinate around getting back that patient experience? And I'd even advocate not only patient experience, but also can we start tying in about patient empowerment? The lowest hanging fruit in population health, if we were able to convince everyone to exercise and eat right, and a lot of the innovative stuff, Blue Cross has a partnership with the YMCA now. If we have pre-diabetics, if we can get them into the diabetes prevention program, and Blue Cross helps to reimburse that, and we're able to get that patient exercising, dieting, so in 13 years from now, we're not paying for a diabetic amputation. That's the long-term cross-generational. And so I do think, yes, tying in the patient satisfaction and some patient measures, but also trying to even involve that a little bit more from patient empowerment. How do we, as providers, empower our patients to improve their care?
Hemi, you look like you wanted to add something on this.
The one thing I wanted to just chime in on is I think the quality measures and the uniformity quality measures, including the patient perspective, is so important. And I just throw out Vermont and Minnesota have done a lot of work on that, really digging in to figure out, and it was hard. It took them years. What is a common set of measures across all the payers? And I think it's been important in some of the work that they've been doing. So I just share that for you all.
Yeah, there is a lot of interest in this. I know as we've been involved with it at Duke Margolis in aligning, especially on the commercial side, in meaningful measures and making sure across the board that the measures are tied to outcomes that really matter to communities and the people in them. So definitely getting a lot of attention here. Do we have time for one more? One more? Okay. This side maybe.
Hi, Cedric Baker, Jamu, the food pharmacy. Have a quick comment, which could lead to hopefully discussion from the.
Well, it's not going to be a long discussion, but
it's a quick question. It's a fundamental issue. Dr. DeSalvo mentioned it, and it segs into something Dr. Rajkumar said, and that's medical education and the education of health professionals and potentials for innovation and how this training can impact social determinants of health. Tulane had this program, actually her alma mater, where they had a teaching kitchen. They had a physician come in and teach medical students. They would go shop and they would make these healthy dishes. And in the analysis, the first analysis, 600 medical students had yielded novel rewards and led to a downstream cascade of various benefits in training for social determinants of health. And that segs into what Dr. Rajkumar said about concierge service of shopping with diabetic patients, with physicians. And just the last point is our community pharmacists are our most accessible health care professional. They could do nutrient drug interaction screenings of every patient on medicines. This is very much an looked at area because you have a lot of drugs that cause nutrient deficiencies or toxicities.
Yeah, lots of potential opportunities out there. Yeah,
I mean, this is one of the things that gives me the greatest hope. So if we were to end this panel on a note of hope, that I finished my training at Brigham and Women's Hospital in Boston about 10 years ago, and when I finished my training, half of my class went off to do cardiology fellowships, half did other specialty fellowships. And I felt like I was walking off a plank because this field, whatever you call it, population health or leadership or systems change, wasn't a thing. Now it's a thing. And there is a cohort in every leading program, every medical school of bright and committed individuals who are smart, who want to do this work. And that, it is amazing. And this has happened in less than one generation.
I'd say the same thing from what we see at Duke. A huge amount of interest, not only among physicians, but nurses, other allied health professionals, people in law, et cetera. It's changing. You had a comment, Victor? I know okay. Well, thank you all. I want to thank the panel. We could obviously go on for a long time, but this is where the rubber's meeting the road, doing a great job.